Now, cancer pain is slightly different from non-malignant chronic pain in that usually progression of pain is more rapid in the cancer setting, particularly after treatment has been ceased. And the problem is that worsening pain often heralds a poor prognosis. The pains are usually multiple in cancer patients, and normally cancer patients in the advanced setting will have around about 3 different sorts of pain. It's often associated with other physical symptoms rather than just pain. For example, there may be problems with nausea or vomiting. There may be issues with constipation in association with the drugs. There may be significant issues in terms of appetite as well. And obviously, because they have cancer-related pain and because they're going to deteriorate, it's often more distressing and more emotional than chronic non-malignant pain. So there are a number of reasons why patients may have pain that's not adequately controlled, and some of those may be associated with the patient and the family. There has been a belief in the past that pain is inevitable and untreatable, but most patients and families realise these days that treatment is available and usually adequate. Sometimes it's because they try to put up with the pain and don't contact the doctor, and when they do see the doctor, the patient says things aren't too bad, whereas the family knows that this is not the case. Sometimes patients fail to take medication regularly, and that's usually because of side effects rather than anything else. Sometimes patients believe that they should only take the drugs if it's absolutely necessary. The fear of addiction associated with the drugs, the opioid drugs in particular, is much less of a problem than it has been in decades past. Patients do have talk about the fear of developing tolerance to the drugs on occasions, and therefore they don't want to progress to stronger drugs if they can avoid that. Patients may stop the drugs because of adverse side effects like nausea, vomiting, constipation, or cognitive impairment, and they don't notify the doctor, and therefore they get back into the pain cycle again. Sometimes it's the healthcare professionals that may be at fault. Hopefully these days doctors and nurses are aware that pain can usually be treated quite adequately, and it's certainly not inevitable or untreatable. Sometimes healthcare professionals may not be aware of the intensity of the pain, and really it gets back to believing the patient's story when they're complaining of pain. So one has to actually try and get behind the brave face if that appears to be an issue. You don't want to prescribe analgesics that are too weak to do the job, and usually with cancer-related pain you need to prescribe regular analgesics rather than ones that are just taken as needed. Doctors and nurses sometimes fail to appreciate the size and doses that are required, and we sometimes need to give quite large doses to patients to get adequate control, and this concept of pseudo addiction can become a problem. When you're prescribing drugs to the patients, it is important to give adequate instructions about how to use the drugs and how to record the way that they use them as well, particularly when they're starting off on these drugs. The doctors may not have a full appreciation of relative potency and rotation to other opioids. There may be some fear about addiction for the patient, although once again these days I think most medical practitioners would be more aware of the situation and not become concerned regarding increasing doses of opioids. And there may be a problem with a lack of knowledge about other co-analgesic drugs or even other delivery systems, which may be very important in terms of symptom control. Reserving strong opioids for the very end is not appropriate. There are other non-drug measures, and obviously radiation treatments can be very useful for bone pain. It is important, if pain is an issue, that the pain is actually monitored, and patients can be actually asked to keep a diary of their pain, and that may be important in terms of looking at dosages of drugs and also changing drugs, in other words opioid rotation. And so all of this gets back to adequate communication and support of the family, and that's not just from the doctor but also the other health professionals that are involved. So there are different types of pain for the palliative care patient. Pain may be directly and only from the cancer, but there may be other pathologies as well. Pain may be related to treatment, so that may be post-surgical pain, certainly post-chemotherapy pain in terms of peripheral neuropathy associated with the drugs, or mucositis. Similarly, in radiation treatment, mucositis or esophagitis may cause significant problems. It may be related to other comorbidities, so a patient may have significant issues with ischemic heart disease or chronic joint pain related to rheumatoid disease. And then finally, it can be related to their weakened state. Often as patients become more bedridden and immobile, they're more at risk of pressure areas and also develop generalized muscular pain. So pain can be classified in various ways. It can be physiological pain or functional pain. There can be nociceptive or nerve compression pain. And then there's true pathological pain, which can be either nociceptive and either somatic or visceral, and then neuropathic pain, such as nerve injury or sympathetic type pain. So muscular pain is not usually a significant issue in cancer, in the setting of cancer pain, but it's important to recognise the patients who do get cramps and to try and give them reasonable advice. It may be a cessation of drug therapy. We know that treatment of muscle cramps is not very effective with any drug therapy. Irreversible cramps can occur with nerve damage, so in association with radiculopathies, plexopathies, and peripheral neuropathies. Myofascial pain can be associated with hypersensitive areas, which are called trigger points, and these trigger points can be very important in trying to settle this sort of pain down. So injection of local anesthetics into these areas can make a significant difference in reducing pain and tenderness. Somatic pain is usually a constant aching pain which is reasonably well localized. It's a nociceptive pain. Bone metastases is a good example of this. It would normally be treated with standard analgesics and perhaps even consider the early use of radiotherapy. Visceral pain, on the other hand, is often less well defined in terms of its site. It can take various forms. It can be constant and aching or colicky. It can be associated with nausea, particularly if you've got involvement of gastrointestinal organs. It's also a nociceptive pain, and pancreatic cancer is a good example of visceral type pain. Once again, it's treated usually with standard analgesics, often in higher doses. There's the potential also to use specific nerve blocks such as celiac plexus blockade. Obstruction to a hollow organ, such as the small or large bowel in particular, is also a cause of visceral pain. And in this setting, standard analgesics may not be first-line drugs, so one may have to consider other drugs such as antispasmodics. Other symptoms may include nausea and vomiting and even abdominal distension depending on the site of the disease, and if possible, surgical intervention may be appropriate, and therefore if one's faced with a situation where the patient has these symptoms, then a surgical review may be worthwhile. And as I mentioned, the drugs may include antispasmodics and antiemetics, as well as other anti-secretory drugs, and then standard opioids may also be useful if there is significant background pain.